morning, everybody. My name is Dr. Pragnesh Pokar. I am from Qure.ai, and today we are going to have a discussion on AI in neuro-critical workflow. And today we have our panelist, Dr. Alex Novak and Dr. Remy Lobo. Thank you so much for joining us today. And so to start with, let me just introduce Dr. Alex Novak and Dr. Remy Lobo as well. Dr. Alex Novak is a renowned emergency medicine physician and researcher with over 20 years of experience. He is a consultant in emergency medicine and ambulatory care at Oxford University Hospitals NHS Foundation Trust and a honorary associate professor at University College London. Dr. Remy Lobo is a distinguished neuroradiologist at the University of Michigan Health System with over 11 years of experience. He previously served as a neuroradiology fellow at the University of Utah School of Medicine and a radiology resident at Indiana University School of Medicine. Thank you so much, Dr. Novak and Dr. Lobo. Thanks for joining. So we start with the discussion on impact in AI in neurocritical workflow. And the first question to start with is, Dr. Novak, how do you see AI currently being helpful in ER and ED workflows, and especially in the neurocritical scenario?
Fine, thank you. But yeah, so the question was around ED workflows, particularly in the emergency department, and how AI is helping. So we're relatively sort of early in terms of adoption. I'm going to speak very much from a UK perspective because that's where my experience lies. In terms of adoption in the UK, essentially there's pretty much just one algorithm at the moment, which is very sort of niche, very specific, which is Brainomics, which is looking at sort of stroke pathways particularly. But we're doing a lot of work in terms of evaluation in partnership with Qure, in partnership with other vendors. And we're sort of only at the stage of sort of generating a lot of information through reader studies and increasingly moving towards prospective studies. The emergency department, for context, is a very big user of diagnostic imaging. We see about 26 million cases a year in the UK, so huge numbers. About 56% of those will receive some form of imaging. So it's a pretty important use case for us, a very important sort of diagnostic field for us. And anything which improves efficiency or improves pickup rates or allows us to adapt those workflows to optimize them is a real powerful intervention. And so this is what we hope for from AI. Moving more locally to what we're doing at the moment and what we're doing with Qure, we currently have a reader study which is called AI React, which compares the accuracy of clinician and radiology readers with and without AI. And we've just got the data through that. In fact, it's sitting in my laptop over there at the moment. I have yet to analyse it. Work for the plane on the way back. So that took a number of readers together and got them to go through about 120 CT cases each. And really what we're trying to explore there is what the impact of Qure and other sort of algorithms would be on both general radiology capacity and accuracy, but also actually looking were in sort of low risk cases, would emergency physicians be able to discharge potentially sort of non-clinically serious cases where there's a low likelihood of severe harm, and to wait for a sort of later radiology workflow, radiology report later on. So trying to adapt workflows in that kind of way.
Thank you so much, Dr. Novak, for the insights. So in terms of latest advancements in the neuroradiology space, Dr. Lobo, would you like to just comment on or provide any particular comments from your end?
So we were talking about this earlier as well. Excuse me. We were talking about this earlier as well. As I don't look at AI as replacing the radiologists. I look at it as us making us better radiologists, and I'm not scared of AI as much as I embrace it to help make me a better radiologist. So I love it from that standpoint. So the things that really help us in our workflow are triage. Anything that triages our work is better, right? So if you have 40 CTs that come from the ER, you say 56% get imaging, they all get imaging. So I mean, we get so many studies that go through, and we don't know which ones are the ones that are really urgent. They're all stat, but how do you know which one is stat and which one is not stat? So having something in our list which was flagging them, working in the background, pulling them to the top, and getting our eyes on it faster, so we can make calls faster, so they can make interventions faster. So as we all know, time is brain, and for neuro especially, we're looking at strokes, we're looking at hemorrhages, we're looking at things that get treated quickly. And so I think from that standpoint, that's what we want. And that's what we're using, and that's what I think will help us in the future. And then beyond that, quantification methods are going to be helpful for the kind of day-to-day. Like once you get through the stat ER parts, then you want is the hemorrhage same, better, worse? So you get difference maps. Is there more blood? Maybe neurosurgery is going to get a quicker consult on that one versus the unchanged, which they can wait longer on. So part of it's triaging the workflow and making sure what we are providing in our reports and who we're calling is most usefully prioritized to help people in general. Did I cover all of it?
Thank you so much, Dr. Lobo. Just to also talk about the stroke management and diagnosis. So basically in emergency settings, how do you see AI influencing that? Dr. Novak, if you would like to take that question.
Yeah, I mean, I can talk. We've got sort of good track record of this in the UK, and we already use AI, particularly in the sort of the high risk, high urgent cases. So cases to decide on thrombectomy versus thrombolysis, and the AI can work in a lot of ways. I mean, in terms of sort of case detection, picking up edge cases, picking up serious cases, but in particular, and I think Remy sort of alluded to that improvement in workflow time, especially that time as brain phrase is really critical in stroke. And so being able to optimize both the detection of potential cases for thrombectomy, for urgent interventions, and get those images to the decision makers really quickly, and as part of a sort of wider kind of ecosystem and an IT ecosystem. And that's already been shown to be beneficial in stroke, and I think that's very much here to stay in that pathway.
I think we were talking about this before, and I think there's an opportunity there as well in terms of integrated healthcare teams, right? So you're the ER physician who sees the patient when they walk in the door. I only see the patient pictures after they hit the CT scanner. But then there's a neurologist that's already seeing the patient, and then probably a neurointerventionalist is going to possibly be involved in that too. And so anything that connects us faster via quick notifications and kind of makes all of those things go to the comprehensive stroke center makes the treatment better, right? So working in the background, sending text page notifications or push notifications on an app where you're able to see that and link people in faster. That's the gift, right? That brings everybody together quicker, and I think that's a real powerful opportunity and benefit.
If I can just add, actually, I absolutely back that up, because we've really seen that in the UK with the way that stroke teams and multidisciplinary teams have come together, and stroke networks, and I think there's been a real push to get thrombectomy into the UK, and actually the AI has been a real quite critical part of that.
No, I think that those are really interesting insights from each one of you, especially from the UK and the US region. I think having that diverse particular experience really helps. But in your experience, do you see implementing the AI in neuro-critical care has its own set of challenges? And if yes, what would that be?
Should I take that first? Yeah.
Either one. So for us, it depends on what kind of workflow you have. So whether you are, it all depends on where you want to put your focus. Do you want to put your focus at the ER, kind of in the medical record and hunting in the medical record as to how a patient shows up, what's in the triage note? Do you want to do it in the evaluation or in the pages that go out? Like, where's the notification start? For us, I mean, I work in a radiology-driven workflow, so I know it feels like ER, but it's really just radiology. So I look in the radiology workflow, so once a picture's taken, then I'm involved. And so at that point, I want something working with the images at that point. And so for us, that's to be integrated with our radiology system. So however you're reading, it's got to load to that system. It's got to flag in that system and have a good working relationship with your PACS vendor in order to make things pop up and down on your prioritized work list. So for me, the degree of integration with your third-party vendor is crucial in terms of delivering a high-quality product that can make an impact. So it's got to flag to the radiologist, and if 3 or 4 of us are reading and I'm bogged down in some certain study, it'll flag to one of my colleagues who's wearing a similar able to look at it hat, and they can get that study, sign it, call it, be done with it. So that's the idea for us. I think that's that integration is crucial.
Yeah, I mean, I think our issues in the UK, perhaps we're sort of behind a little bit in that sense, and our issues are a little more banal actually. And one of the things we've noticed, especially with the other study that I forgot to mention, which is Accept AI, which is looking at the Qure in 4 sites in the UK: Glasgow, Oxford, Northumbria, and in London, and actually just trying to sort of evaluate that prioritization function within that. The challenge has been the administrative, very much so in the NHS, and there's still a lot of organisation and optimization of the adoption processes in terms of administration and the IT governance and all the sort of different sort of facets of that, and that's really slowed. It's been striking in that study. It's really slowed our ability to get that study going, and that's clearly going to be a barrier. So I think that's something we've got to work on in the UK a lot. Is actually looking at those administrative processes and trying to streamline that, trying to focus it and make it very AI ready, essentially.
Sure, thank you so much. So one more question which I had is, in case if you have a wish list which you might have for AI in neurocritical care, what would that wish list be, and what do you envision AI will be for supporting neurocritical care, possibly in various ways?
So this was for me. So from an ED/ER perspective, I think what we would like to see is being able to unlock some of the potential to perhaps manage our workload, to treat different cases differently, I guess. And I think AI might offer us a chance of that. I mean, I think ultimately, this is, again, it's not looking to replace neuroradiologists for sure, but everybody's busy, everyone's slammed. And I think that helping sort of prioritize those cases. So I think we know that in a large proportion of attendees for emergency departments in the UK, and I'm sure in the US as well, the vast majority of test results are normal. These guys are okay. And actually a lot of this, you can kind of surmise when they're seen, but they have something in their story or there's something in their presentation that makes you think, well, actually, we need to get a scan to rule that out. The scan always looks normal to the ED physician. We're not supposed to, but we always have a quick look. And I suppose something that would actually just turn that engagement with the imaging into some useful action, perhaps to optimize whether people can be sent home on a different care stream. Maybe they can be sent home and followed up later to wait for a report. So I think we're on the right lines with that, actually. But I guess what we want to see is a really good spread of functionalities in the AI detection stuff, so that it's not missing edge cases, it's not missing the sort of rare but critical findings, and just something robust and some robust evaluations that actually would allow us to sort of move confidently forward with that.
So I'm going to come at it again from 2 different points. Is the focus imaging or is the focus medical record? And those are often not the same. So from the imaging standpoint, I want all the quantitatives I can get. So flag everything, put ROIs on everything, put little margins on everything, use pink for one, yellow for another, green for that, it's fine. So then I can compare them, go back. And so you want to be able to get the current study, flag what is or isn't abnormal on a current study, and then have it flag also the comparison and or priors, and then you can create differences, right? Differences over time. And I think that's very powerful, be it ventricle size, the amount of hemorrhage, the size of the infarct, the amount of shift. And so you can very quickly have those outputs, have them text exportable and show up in your dictation. Bang, done. Then I can say, yes, agree, yes, agree, yes, agree. I want to say 2 other things and I'm done. And it's great. From an efficiency standpoint, that's wonderful. Then from the medical record side, you want it to be able to scour in the medical record and pull things out. And this is beyond the scope, but the medical record is very large and very useless in many ways. So there's a 70-page note with nothing useful in it. And so you want to be able to find what's useful and to pull it, and you can create algorithms for that. And I think something that speeds up our ability to not spend time looking in the medical record and have me as a radiologist spend more time looking at pictures is great. Because I want all of my time looking at the picture, very little time hunting in the medical record, and even less time working on a dictation. So those are like keep my eyes on a screen, the one with the patient pictures, and I'll be a much better radiologist and a more effective one. So that's kind of how I look at it.
No, those are great insights, I would say, Dr. Lobo and Dr. Novak as well for the challenges which we see and what could be the wish list for AI in the neurocritical space. One last question, which is, so as you know that many physicians or radiologists as well, they dread AI replacing them. And I think this is something which is a fear, which I personally believe is not. AI can never replace physicians or radiologists. But what is your take? How does AI and humans collaborate and make the patient care better, or maybe look at the effective optimized patient management?
Well, I think you articulated it well, actually. I think these things are supposed to be an adjunct. They're supposed to support clinicians and radiologists in making their decisions. I'll defer to Remy on this one, but my sense is actually that radiologists don't fear AI, and perhaps in the way maybe a few years back there was this concern. I think, everything I know of radiologists and certainly clinicians, are very, very busy. There's a lot of work to do. So I don't think there's much threat in losing that. Maybe the relationship will evolve. I suppose in terms of how you achieve that, I suppose for me it's just one word, which is co-production, and that's really what you see here, isn't it? At the conference, there's a lot of people engaged from all different stakeholders and bringing all the kind of key voices from the pathways into the actual development and evaluation processes, and that's the way it'll work well, I think.
I think I said that's the first thing I said is I don't fear it as much as I think the radiologist should not fear AI. You should embrace it, because the idea is it's going to make you a better radiologist. I don't think you look at mammography, was it 40 years now? A long time ago, mammography's had CAD. They didn't become worse at mammography because they got CAD. It just got them better faster. And the pros look at the CAD and be like, psh, silly CAD, and they let it go. Or they're like, yeah, hey, I agree with that. And they get you better faster. And so it just draws your eye, one more look. All of our patients want one more look. Every clinician says, can you take a quick look at? None of our looks are quick, but one more look. And it's always just one more thing. Yeah, I looked at that. Okay, good. Or yeah, oh yeah, I think that's right. So will it make me better? Yes. Should I embrace that? Yeah. That's kind of how I think about it.
Sure. Thank you so much, Dr. Lobo and Dr. Novak. Thanks for joining us today. I think great, insights which we have received from both of you. Also, I think a lot to learn, which a lot of learnings as well. And thanks for joining us today. Take out your time. Really appreciate that. And thank you so much. Thanks.